Many experts think the key to controlling healthcare costs is a change in how doctors and hospitals deliver care to individual patients. And that can only be achieved through payment reform. So we're going to look at a series of payment reform efforts contained in the Affordable Care Act. Another effort at cost control is something called the CMS Innovation Center, or CMMI. This is a provision in the bill that creates this innovation center, which is supposed to run experiments or trials about how to transform care and improve the quality and reduce the cost of care. It has $10 billion to be spent over 10 years to try innovative programs and try a variety of ways of saving money. Finally, there are efforts at bundle payments and ways of testing bundled payments. Now, right now in the healthcare system, doctors and hospitals are paid fee for service. That is, they're paid for each part of care that they provide. So take a hip replacement. Surgeon is paid one bill. The hospital is paid for the operating room and the overnight stay, a second bill. The anesthesiologist is paid. The rehabilitation facility is paid, and any medications are paid. Bundled payments changes this by giving one fixed price for the whole arrangement. Having a fixed price incentivizes both the surgeon, the anesthesiologist, the hospital, the rehabilitation facility to work together to try to streamline the care. For example, they might bargain hard to get the cost of the hip replacement down. They might change how they offer rehabilitation to do it in a more cost-effective facility. They might focus on trying to care for patients so that they don't get infections or other complications that might add cost. So bundle payment incentivizes doctors and hospitals to provide efficient, high-quality care. In fact, Medicare has run an interesting demonstration project on bundle payment called ACE, or the Acute Care Episode. This is a project that is run for cardiac procedures, things like bypass surgery, stents, catheterization or pacemakers, as well as hip and knee replacements. It was run at 5 sites for those different cardiac and orthopedic procedures. After 3 years, Medicare evaluated the program. It saved on average $319 for Medicare per patient and over $4 million across the 5 sites. Hospitals saved even more, and those savings were shared between Medicare and the hospital. Medicare is allowed to generalize these programs to the whole country if they save money and keep quality the same, or improve quality and keep costs the same. All of these provisions of the Affordable Care Act to control costs, the ones affecting price by trying to keep prices down, whether reducing the prices for Medicare Advantage, reducing the prices paid to hospitals, reducing prices based upon fraud and abuse, or competitive bidding, as well as transforming how care is delivered to make it more efficient and to use less services and get the same outcome. All of these things have had a very important effect on savings. For example, the Medicare Trust Fund has been extended 10 years. Before the Affordable Care Act, the Medicare Trust Fund was going to run out of money and rely on general revenue before the end of the 2020. But the trust fund has been extended 10 years because of savings in the Medicare program. More importantly, the Affordable Care Act is fiscally responsible. By cutting programs and adding revenue, the Affordable Care Act does not add to the deficit one penny. In fact, the Congressional Budget Office has assessed that the Affordable Care Act is actually going to contribute $100 billion by the end of the decade to deficit reduction, and almost $2 trillion by 2030 in savings. So the Affordable Care Act was designed to be fiscally responsible. So we've seen that the Affordable Care Act has a number of cost control mechanisms. It reduces prices to save money by reducing excessive payments to Medicare Advantage plans, by fighting fraud, by having administrative simplification to reducing paperwork, and introducing competitive bidding to reduce the prices that Medicare pays for things like hospital beds, oxygen equipment, walkers, and wheelchairs. It also tries to transform care to reduce the volume of services provided through the Cadillac tax, that's the excise tax on high-cost insurance plans, through accountable care organizations or ACOs, through the IPAB or the Independent Payment Advisory Board that recommends changes to save Medicare money, through the Innovation Center, bundled payments. All of these programs are meant to keep costs down. Now, they're not going to be enough. We always have to look at costs and always think of new programs and new efforts to reduce costs, because healthcare inflation is always a threat. It's a threat to the budget, it's a threat to take-home pay, it's a threat to states, and we have to be constantly vigilant on healthcare costs. So we've looked at access expansion under the Affordable Care Act, cost control under the Affordable Care Act. Next, we're going to examine quality improvement under the Affordable Care Act, as well as other less well-known provisions, such as the public health measures or prevention of obesity provisions, as well as how the Affordable Care Act tries to improve the number of physicians caring for patients, as well as the mix to improve the number of primary care doctors.